over to you, Isla.
So, good evening, everybody, and welcome to our inaugural BMMS Journal Club meeting. I am Isla Wormold. I'm an emergency medicine and pre-hospital emergency medicine registrar based in South Yorkshire. I've just come back from my 4th season working for Antarctic Logistics and Expeditions in Alzarrad, Antarctica. Thank you very much for joining us this evening. The aims of tonight are to jointly dissect and digest literature pertaining to the practice of mountain medicine, to inform our clinical practice, to provide opportunities for shared learning and academically rigorous CPD as required for appraisal and revalidation, and to encourage reflective practice.
Still not got too many people in.
So
thousands will be watching on the recording.
Chatham House rules are going to apply if once we have spoken about the paper and critically appraised it, people want to contribute info from their personal experience, then we would ask that they do not reveal the identity or affiliations of patients or workplaces associated with those stories. We are going to try and create a safe learning environment where we can disclose sensitive information and discuss, understand and resolve complex problems as a collective. Everyone here is identified as a healthcare professional. They've been asked to prove their identity to be able to join. And in terms of housekeeping, if you could keep mics off if you're not speaking, that would be great. And we will ask people to turn cameras on during the discussion at the end. Feel free to use the chat function to ask questions or liaise with presenters. So for the introduction, I'm going to invite Kitty Duncan to the stage. Kitty is an anaesthetic consultant currently up in Orkney. She is a holder of the Diploma in Mountain Medicine and an aeromedical retrieval and pre-hospital emergency medicine PG cert, and she is very experienced in the practice of mountain medicine. So I'm going to stop presenting and hand over to Kitty. Thank you, Kitty.
Okay, I'm going to put my presentation on. Can you see that? Yep. And can you hear me? Yep. Excellent. Okay, so I was asked to do a short introduction to lidocaine, as we now call it, because I'm old, I still call it lignocaine. Just to go over some pharmacology of the drug before we talk about the paper. So that's what it looks like. And what is it? So most people would say the answer to that was local anaesthetic. Of course, us anaesthetists have to learn a whole load of stuff about it for exams, so we have a much longer answer. So what it is an amide local anaesthetic as opposed to an ester. And that difference is important for various reasons. And the shape of the molecule is important for what it's, how it functions. As we all know, it comes in lots of different presentations and strengths, and is used in all sorts of ways, from topically to intrathecally to intravenous. And the dose is ideal body weight, usually maximum dose 3 milligrams per kilogram, up to 7 milligrams per kilogram with adrenaline. Why with adrenaline? Because it's a vasodilator in therapeutic doses. So if you add adrenaline, you can increase its duration. And yeah, onset time, I put 2 to 20, can be 1 to 5, depending. It depends on how much you're using, where you're putting it, and various other circumstances. And it can last up to an hour, depending on what you're using it for. And as we'll see, when you use it intravenously, its effects can last longer. So ignore the fact that the little yellow dots say cocaine. Just imagine that it says lignocaine, because this is the best drawing I could find of how it works. So how does it work? So the important thing is it has to be non-ionized to get through the neuronal membrane, because it blocks the sodium receptors of the neurons from the inside. And that's important because pH of the tissue makes a difference. And once it's inside, it gets ionized, and once it's ionized, it can go inside the sodium channel and block the sodium channel. And if your sodium channels don't work, then you can't propagate and your nerve conduction, and your nerves won't work, and therefore you become numb, or you get the effects of local anesthetic. So that's a very simplified version of how it works. Just ignore the small writing at the top of this slide. That's just me reminding myself how it works. So as I said, pH of tissue is important. That's why a lot of the time you're told you can't use local anaesthetic when tissue is infected, because it tends to be acidic. And if you add bicarb to it, then you can actually I can increase speed the onset of action, because you're making more of the anaesthetic in the non-ionized form, so more of it gets through into the neurone. On top of this, if you get to doses that we're talking about intravenously, it also binds to NMDA receptors and muscarinic receptors. And it's probably through this that it has some anti-nociceptive, anti-hyperalgesic and anti-inflammatory effects, which we see using intravenous infusions in hospital, because you get an after effect quite a long time after the anaesthetic has actually been stopped, been given. So then we get on to all the exciting pharmacokinetics, pharmacodynamics. I don't think even us anaesthetists get excited by this. So absorption is very much related to the site of injection, makes a huge difference whether you're using it intravenously, intrathecally, just doing field blocks, and also whether you use vasoconstrictors. Metabolism is in the liver, and some of the metabolites are active and can reduce the seizure threshold, and the metabolites are then excreted in the urine. And really, really importantly for lidocaine, is it has a narrow therapeutic index. So plasma concentrations are quite important if patients do have liver or kidney failure, because you could very easily get toxic doses. And what are the non-analgesic effects? So allergic effects in amide anesthetics are extremely rare, more common in esters. And the main effects that we talk about when we're talking about toxic effects are in the CNS, the respiratory system, and the cardiovascular system. So the CNS system particularly has a biphasic effect. So initially you get excitation. So patients can get tinnitus, tingling, and feel dizzy. And that's what we often ask about in anesthetics when we're doing epidurals and things like that, to check that patients aren't getting toxic. But then it can go on to seizures, and then you get a proper depression effect where you can get confusion and the worst case scenario, coma. Respiratory, normally it produces a bit of bronchodilation, not therapeutic enough, but it does. But in toxic doses, it causes respiratory depression. And then cardiovascularly, normally you get a bit of increased systemic vascular resistance, but in toxic doses, you're getting decreased SVR, so you get hypertension, you get reduced myocardial contractility, and when things get worse, arrhythmias, because we know that it affects the electric system of the heart. And you can get methemoglobinemia, but that's reasonably rare. So that's all the bad stuff that it can do. And remember, again, narrow therapeutic index. So what do we use it for? I mean, it's pretty ubiquitous in hospital and GP practice. EMLA, we're using that all the time. It's an Instagel. We use it for infiltration, especially surgeons, and us anaesthetists use it for nerve blocks. And then you're talking about IV use. So IV use used to be just for ventricular tachycardias, and now we are using it more and more for post-operative, perioperative pain, usually only in an HDU setting. And this is my most important line of my whole thing, is that anaesthetic guidelines say that you must have intralipid rescue if you're using local anaesthetic, especially intravenously, in case of cardiovascular collapse, because that is your one thing that you can give as a direct treatment. So when shouldn't we use it intravenously? Obviously allergy and anything that's going to affect its metabolization, so liver failure, reduced portal blood flow, and then anything that's going to interact in terms of what it does to the heart electrical system. So any cyanoatrial disease, any degree of AV block, and also any It'll interact with any drug that's going to cause myocardial depression, especially beta blockers, and any drugs that increase QT, which are quite ubiquitous. As we know, these days, a lot of people are on either beta blockers or something that increases your QT. So there's lots of reasons to be careful. So this is what we're talking about for this paper. So IV analgesic lidocaine. So first important line, not actually licensed for this. There is an international consensus statement, I can't remember who, by a bunch of anaesthetists, important ones, who set out this consensus statement for use in post-operative pain. And that they said that it's a high-risk medicine that requires local governance approval and consented patients, very important. You should have continuous HDU style monitoring. You should always be using ideal body weight for calculating your dose, and that their protocol, which is the one I have used in my practice, is a bolus dose of 1.5 milligrams per kilogram over 10 minutes, and then 1.5 milligrams per kilogram per hour for 24 hours post-op, if you can stop the toxic effects happening, which is pretty common. And that is the end of my introduction. So I'll try and stop sharing my slides. There we go. Back to Isla.
Thank you for that, Kitty. Okay, so I have initially attempted to summarise our paper. So essentially, it felt to me like the authors were trying to make the point that analgesia in austere and resource poor environments is a challenge, which I'm sure as pre-hospital practitioners or mountain medicine practitioners we can all agree with. They were trying to make the point that in mountain or austere environments that the limitations were often environmental. So, you know, environmental conditions will affect how we're able to give analgesia. Often, as I've said, we're in a resource poor environment, so we have limited equipment, and limited supplies might also include medication itself. You know, is the medication durable? Is it reliable? How's it been stored? What's its side effect profile? How big is it? How heavy is it? Etc., etc. And also personnel can be a limitation as well in terms of experience, training, competency, etc. They were obviously considering the use of IV lidocaine as an analgesic in a resource poor setting, and they were, I think, by reporting these two cases, trying to demonstrate its efficacy as a potential mode of analgesia. In terms of design, setting and participants, so not your kind of typical paper for critical appraisal, I appreciate, but I thought it was interesting nevertheless. It's a retrospective case report. The setting was a clinic in Southeast Asia, and they mentioned that they're restricted by their choice of analgesics available. So I believe that they were paracetamol, with, I think, the maximum available of 5,000 milligrams, which was meant to be for treating fever and pain. They said that they had a limited supply of ketamine as well. So I think it was 6,000 milligrams of ketamine available, and the clinic tended to reserve that for procedural sedation. And they had a robust supply of lidocaine, but no supply of intralipid. They also mentioned in the paper that they had infrequent resupplies to the clinic, an unreliable electricity supply, limited equipment, so no infusion pumps, no refrigerator, no imaging, and they had a 2-person doctor paramedic team. The two cases that were reported were one of a 22-year-old female who had, they believed, fractured her left fib, having fallen off a moving motorcycle. And the second case was of a 38-year-old male with a past medical history of opioid use disorder, who had fallen greater than 2 meters off a ladder and had been supposed to have fractured his left posterior 5th rib. In terms of the interventions that they looked at, so they were obviously giving intravenous lidocaine at a dose of 1 milligram per kilo per hour IV, and they were attempting to administer it, given that they had no infusion pump, using drip rate. So different IV administration sets, it's useful to know, have different drip factors printed on their packaging because they all deliver fluids at varying rates. So they were trying to calculate drip rate by using the drip factor noted on the packaging. And they were making up their own IV infusions by adding the 1% lidocaine to a known volume of crystalloid. So in terms of outcome measures and results, they were using the Defence and Veterans Pain Rating Scale, which is apparently a reliable and valid pain assessment tool, which uses a numerical rating scale enhanced by functional word descriptors, colour coding and pictorial facial expressions to match pain levels. And there are 4 supplemental questions that try to assess the effect of pain on activities of daily living, sleep, and how badly the pain influences mood and stress. So that was the rating scale that they used to measure pain in both patients. They showed that with the use of IV lidocaine, pain scores were reduced from, in case number 1, 8 out of 10 pre-treatment to 3 out of 10 post-treatment, and in case 2, 9 out of 10 pre-treatment to 4 out of 10 post-treatment. They also appeared to comment on the onset and duration of action, but that is in line with what we already know about lidocaine. And for case 2, there was some comment about patient physiology, which seemed to be used as a marker of improved symptom management. So they commented that the patient's pre-IV lidocaine respiratory rate was 35 breaths per minute, which was reduced to 18 post-treatment. And they commented that his oxygen saturations were 93% on room air pre-treatment, and they improved to 98% on room air post-treatment, presumably as a consequence of reduced pain with chest wall movement and improved breathing. The other outcome measures seem to be the frequency of, or the experience of, adverse effects, which they note as tinnitus, but there were no other adverse effects noted. So the conclusions that the authors seem to come to are that IV lidocaine created analgesia without impaired mentation. They did make a statement that regional anaesthesia they felt would have been beneficial to both patients, but unfortunately there was nobody trained in regional anaesthetic techniques to be able to administer regional block. They mentioned that they feel that IV lidocaine should be considered if traditional modalities are unavailable, exhausted or unsuitable. They seem to comment that they felt perhaps it should be used in a reduced dose and with cautious administration, and that it could be perhaps used in multimodal analgesia. They also made the comment that they felt that there was further research required to identify best practice, appropriate patient populations and optimal methods of administration. So in terms of my critical appraisal of the case study, so as I've said, case reports I know aren't often critically appraised in a formal fashion, mostly because I presume there's no hypothesis testing, there's no comparisons made in case reports, and it's quite difficult to extrapolate conclusions to other circumstances or other patient populations. However, I think they do have educational and scientific value. And I managed to find a checklist, a critical appraisal checklist in draft form on the BMJ blog. So that's what I've used to look through the article myself. So first checklist item, has the case report been peer reviewed? So it's published in Wilderness and Environmental Medicine, and it would appear that all publications in EMJ have been peer reviewed. The website states that the manuscript will be referred to acknowledged expert peer reviewers and, if appropriate, an associate or section editor prior to the editor's decision republication. And that clearly, if there's a conflict of interest, then reviewers should say so and remove themselves from reviewing panel. But the peer review process is not explained on the website in any greater detail than that. So it wasn't particularly clear exactly what would happen to me. Does the case report have a clearly defined focus? I felt like it did. They were looking at the use of IV lidocaine as a form of analgesia in a resource poor setting. Query using it as a novel treatment, I suppose. They were addressing the clinical conundrum that we frequently face in austere environments, and they did seem to touch on the fact that one should consider risks as well as benefits. Are all the necessary facts presented? So I didn't feel like they were, in terms of the information that we got about the actual patients themselves. So they commented for the patient in case number 1 that she had no life-threatening injuries, and that her extremity was neurovascularly intact, that the intervention, i.e. the use of IV lidocaine, facilitated splinting, and that she was subsequently discharged with oral paracetamol. But there was no other information available regarding her history. So, any of the medication used, any allergies, how much did she weigh, or what was her ideal body weight? Was this an open fracture? Was there any skin involvement, etc., etc.? And similarly for case number 2, so the authors commented that case number 2 was seen to have shallow effort of breathing, and did have bilateral breath sounds and a central trachea with no jugular venous distension. So I presume that what they're implying is there, given that they've got no form of imaging, is that they didn't believe that this patient had a pneumothorax. They mentioned that administration of IV lidocaine enabled transfer to a nearby location and enabled the patient to resume his duties as a medical assistant. But again, no further information really regarding his regular medications, allergies, past medical history, other than the fact that he had opiate use disorder. No comments on any other injuries, etc., etc. Is the case report linked to the existing literature? So the authors do mention the use of IV lidocaine in peri and intraoperative settings, as Kitty alluded to its use earlier. However, they do not comment on whether there have been similar case reports in austere environments or other resource poor settings, and there certainly is no documented literature search strategy available. Is the discussion relevant? So I was unsure, is the honest truth. So they have obviously discussed their rationale, being that they feel that they have limited options in their clinic in Southeast Asia. They have mentioned some of the risks associated with IV lidocaine use, or lidocaine use in general, in terms of local anaesthetic toxicity. They have stated that there is a small therapeutic window and high risk for toxicity, and that therefore availability of intralipid is usually mandated. And they've talked about their patients, both of them, having minor adverse effects, transient tinnitus, and that these can occur at serum concentrations as low as 5 mics per mil. They also suggest that they feel that toxic levels can be avoided by using low dose boluses and infusions at less than 1.5 milligrams per kilo, and that the more significant side effects, cardiovascular and neurological side effects of local anaesthetic toxicity can occur at serum concentrations higher, i.e. 5 to 10 mics per mil. However, there isn't an in-depth discussion re what they thought that their alternatives might be. So they do mention that they have ketamine, but that's normally reserved for procedural sedation, but they don't seem to have or they haven't verbalised that they've considered that as a viable option and a safe option in these patients. And they have also not suggested what future research could or should be undertaken, but they have mentioned that they think something needs to be done in future. Does the case provide any quantitative evidence? So again, I think difficult to answer this question. There's only 2 retrospective case reports included. Both patients received the same dose, 1 milligram per kilogram per hour of local anaesthetic, or rather IV lidocaine, which produced tinnitus. Therefore, can you really extrapolate those results to other patients? Probably not. There's only 2. We don't really know much about them. And, does that also imply if both of them have experienced side effects at that dose, that perhaps if one was going to use IV lidocaine in future, that it should be used at a lower dose still? They have commented again on onset and duration of action, but we know these things about lidocaine anyway. And since they haven't particularly gone into detail regarding other studies that have been done regarding the use of intravenous lidocaine, and they haven't kind of amalgamated results from other studies with theirs. So I think it's very difficult to say whether there's any quantitative evidence for the use of IV lidocaine in these environments. Is the case report important to your clinical practice? So in some respects, I think it is, because it makes us think about what our potential analgesic modalities are in the pre-hospital environments in which we practice. As I've said, certainly I've found it hard in the past to work out what the best thing to use is, depending upon where I am in the world, what kind of environment it is, etc., etc. It certainly made me think about what I would do if I was in that same clinic in Southeast Asia. And it made me think back again to the importance of risk versus benefit and the kind of old adage of one should do no harm. But equally, this is a case report of 2 patients only. And the setting, a clinic in Southeast Asia, is different to the pre-hospital setting that I would normally work in. And I'm not sure that those 2 patients would be consistent necessarily with the patients that I would normally see in my pre-hospital practice. So, having summarised and attempted to critically appraise, I thought that now we could try and discuss the paper as a group. So I'd be keen to hear other people's thoughts. So I've come up with a couple of questions to try and stimulate discussion, because I think this is probably the most useful aspect of a journal club. So the questions that I was going to suggest that we thought about were, to start with, does anybody else have any thoughts and remarks pertaining to critical appraisal of the publication? I don't know if you want to pop your comments in the chat, if we can invite people, perhaps Chris, to the floor, if anyone has got any other thoughts about critical appraisal of the case study. Anyone? So I'm just reading the chat now. Jeremy says, commonly used lidocaine infusions perioperatively for a range of procedures, a bolus of 1.5 milligrams per kilo followed by 1.5 milligrams per kilo per hour. up to 24 hours. Kitty says, in my experience, it only works as an adjunct in the doses we can give without getting toxic effects. Yeah, I'm going to ask Chris to come to the stage.
Here I am.
Thanks.
I thought it was a very good critical appraisal. And
it was an attempt.
Yeah, I think it demonstrates that. However, it seems a good idea. The methodology that they've used is not very rigorous, but it's good to see that novel things are being tried.
This is true. Dave's wanting a vote of who would use it. So Dave has written in the chat, I'd like people to vote on whether they would like IV lidocaine used on them if they had the injuries described in a remote area, yes or no. Chris, can you do as a poll?
I can indeed. Bear with me.
Dave has also sensibly commented, it's frightening when one realises the number of countries who ban medical use of opiates, thus denying patients optimum treatments. Yes, Dave, completely agree.
I was meant to say in a pinch. Used on me. Oh, it does say in a pinch. So.
It does say in a pinch, yeah. So other things that I thought maybe we could discuss depending upon who's around. What would you do in these circumstances? So if you were the doctor or paramedic in that clinic in Southeast Asia, what would you do for these patients? So I've spent a lot of time thinking about this over the last couple of days. And my feeling is that I guess I could try a regional block, although I always get a little bit twitchy about using regional blocks in settings where you might not be able to ensure the cleanliness of the procedure, because the last thing I'd want to do would be to risk introducing infection. So I think, given that all we want to do for case number 1 is to, by the sounds of things, put her in a plaster cast, I think I'd probably just give her an analgesic dose of ketamine, presuming there were no contraindications to doing so. And for case number 2, whilst he has SATs of 93% on room air, and yes, granted, a raised respiratory rate, and both of these things improved post-administration of IV lidocaine, equally, he then went and was able to go about his normal duties as a medical assistant. So controversially, I probably would have just given him some paracetamol if that was all was available, and then sent him on his way to do, deep breathing and cough practice as per you would do for a HDU patient, because, it has a limited duration of action and he's still going to be in pain from his cracked rib, an hour later. So that's kind of my feeling. I'd be interested to know what other people would do.
Yeah, I'd also be very intrigued to hear what other people would do. Being relatively junior in terms of my genuine mountain medicine experience, it would be good to get that insight from new experts.
So Jeremy says a good dose of an IM NSAID. Don't know if Dave has got any thoughts. I can see him in the corner of my screen, but I can't hear him. Is there any way we can get Dave to be able to speak, Chris? How can we?
Dave, you turned your microphone on and then off again.
Thanks, Kitty.
Sorry, I'm used to sorting out Dave's microphone from afar.
Hi, Dave.
I mean, we don't know what type of fracture this person's got. But currently, in some very unpleasant parts of the world, people are having these reduced quite relatively successfully with no analgesia at all. Do I want some IV lignocaine that can kill me? Or do I want my arm straightened, temporary splint put on, and evacuation? There's always I like this loading dose of paracetamol and non-steroidals, but apparently, from what the accountant told us, they didn't have any simple medication, just lidocaine and some ketamine. Extraordinary. I'm actually rather surprised the journal took this paper.
Kitty, what would you do?
Good question. I would be using the ketamine. I know they're saying they need to keep it, but I mean, they kind of were doing a procedure, so
yeah, I
would titrate the ketamine, so I used a minimal amount of possible, plus paracetamol because they had that. And I mean, I might do some kind of block, but probably not. It depends, on the situation. But I, as an anaesthetist, the idea of using intravenous lignocaine with no monitoring and no intralipid just fills me with fear.
Yeah, agree. Out of interest, what would you have done for the guy with the rib fracture? Would you have done anything at all other than paracetamol for him?
Yeah, I mean, that's interesting. If just paracetamol for rib fracture seems pretty mean because they are really bloody sore. So in that case, I might have been a bit more tempted to use lignocaine, but I still would have had to have a long discussion with the patient. That's what you don't get from the paper is how much they actually discussed with the patient. So, maybe try the paracetamol, get them say, if you really can't cough and anything, come back, because we don't want you to get pneumonia, come back and we will have a discussion about the risks of having a low dose infusion of lignocaine, and then we'll take that decision together. Hopefully you'd be able to do that. So.
Okay, cool. And that kind of, I guess, brings me on to one of the other questions that I thought maybe we could chat about. For the same fella, case number 2, if you were going to provide him with an infusion of lidocaine, having gained his consent, what dose would you use, Kitty? Would you use the 1.5 milligrams per kilo that you mentioned earlier, or given that both patients with their 1 milligram per kilo had transient tinnitus, would you reduce the dose?
That is a tricky question because you don't have monitoring, so you'd be tempted to reduce the dose, but there's no point giving a homeopathic dose. So the normal thing we do is we do an infusion, bolus infusion, and that's where you're more likely to get the side effects, and then the longer term lower dose infusion. And the idea is you want to get the blood levels up. And if you only do the infusion without a bolus, then you're not going to get the blood levels up. Okay. But that's a tricky question.
Sorry.
Maybe use a slightly lower bolus dose and then the infusion. But obviously, I mean, the doses that have been chosen are the ones that actually are hopefully the best for getting an effect versus getting side effects. So it's, you might just end up giving them lignocaine and not actually getting a good clinical effect. So it's tricky.
Difficult.
I mean, you can slowly titrate up from a slightly lower dose and see if they get side effects or not, and see how they feel. When you've got a 1-to-1 person, you're going to be sitting there with them. So you're not going to be wandering around looking after other people. You're going to be sitting there with them. So you could titrate it up and down and see, because the effect doesn't take that long to the titrating the dose up and down, the effects do change reasonably quickly when you titrate, from my experience in ITU anyway.
Okay, so that's what you do. And my kind of last question that I thought we could all consider is, does everybody have a preferred analgesic modality for use in severe pain in an austere environment? So if you could have anything in a high mountain environment in Nepal, what would you choose and why? Dave, go for it.
One word answer to that: ketamine. But more interestingly, they said this guy couldn't have an opiate because he had dabbled in opiates before. If I come across someone on the roadside who's got a history of addiction and is badly smashed up, I have no hesitation in giving them the analgesia they require, and that may well be an opiate titrated IV against their pain level. That's just humanity. One dose is not going to put someone back into addiction.
No, it's a good point. And I don't know why they mention that actually in the case report, given that they've only got ketamine, paracetamol, and what was the other analgesia, and lidocaine. It seems like a bizarre thing to comment on. I don't know whether does that imply that they did have opiates but just didn't use them, or I'm not sure. But okay, so yours would be ketamine. Yeah. How about, I don't know about Kitty?
Yeah, me too. Because you can use it as an analgesic, you can use it as a sedative. It's just and as long as you're used to using it, it's pretty safe. Obviously, a lot of people aren't used to using it, but I've used it for everything, including 300 general anaesthetics in my life, so it's very useful.
Yep.
Yeah, my experience is mostly from sporting events and like basically crewing ultra marathons and stuff like that. And it was actually Dave who taught me this on one of the BMMS courses, that you can just give a stat 2 gram dose of oral paracetamol and it's really effective. So that's, on the more frequent but less severe pain end of things. So I think that would be my pick.
I'm undecided, if I'm being entirely honest, what mine would be. I can see Jeremy's writing in the chat, ketamine, yes, but don't forget methoxyfluorine. And I will admit that I purchased this recently for inclusion in my own mountain medicine kind of medical kit. And it came very close to being used in anger this summer in the Swiss Alps. When a friend ended up with a not insignificant humeral fracture. Unfortunately, I was not nearby at the time, so I could not donate my Penthrox inhaler. But I think is a super lightweight method of patient-controlled analgesia that is not an opiate and doesn't have all the associated problems in terms of crossing borders, etc., etc. I think it's really useful, as long as you're not using it in somebody in whom it's contraindicated.
Yeah, I'd certainly agree there. I'm using it more and more pre-hospital. And it's amazing. You get some people who've been thrown off motorbikes or think they're trapped in a car, and they take a few totes on their methoxyfluorine, and they're suddenly able to get up and move or get out of the car. Quick onset, short duration of action, and it builds people's confidence, as patients' confidence, quite a lot. So I'm using it more and more.
Yeah, I think it's great. I don't know if anyone else has got any other questions that they want to raise and discuss, or any other points about the paper.
I have a question just on Penthrox. Do you think there's kind of an added placebo effect from using it, using like a device that also has an analgesic effect?
Yeah, it's a really good question. I mean, I guess it's it's super obvious that you're doing something. I don't know, Dave, Jeremy, Kitty, do you have any thoughts about that?
Oddly enough, today I've just sorted out a whole load of out-of-date drugs, and I've thrown out a whole load of Penthrox training packs with placebo in. Maybe I should get them out the bin and start using them.
Maybe that could be another BMMS little piece of research, Dave.
Yeah, but there are ethics involved. A lot of paperwork.
Good question though, Chris. Really good question.
I have another question. IMNSAID was mentioned, and I was just curious. I don't think I've seen that in person. What form does that usually take? And does that mean, bringing a vial that you've then got to draw up, or is it ready-made?
That is a great question. So I am not somebody who uses NSAIDs. I don't know whether Dave, Jeremy, or Kitty. Jeremy, I know you're using the chat. What NSAID would you use? I have previously used diclofenac. It didn't go down particularly well with the patient when I jabbed a green needle in her bum, rather.
I think there's often a place in general practice, actually, for, in the old days, general practice, when we looked after patients out of hours. If I saw someone with renal colic or something, I'd often leave them, having dealt with the immediate pain, with diclofenac suppositories at home, and it saved me getting out of bed again later. So I think quite underrated, especially for colicky pains. And the other thing is to remember that if people aren't trained to give injections or IV access, tramadol can be given sublingually. Personally, I don't like tramadol anyway, but it's a drug that I know some expeditions have carried, where it can be just dripped under the tongue out of the ampoule, which is quite useful. So there are a lot of things in the armoury
that can be used.
So Jeremy said in the chat, ketorolac. I don't know if I'm saying that correctly. And diclofenac.
Yeah, and agree.
Fentanyl. Well.
Fentanyl lollipops, from personal experience, I hasten to add, with an ankle fracture, work fantastically. So yes, Jeremy, 100% agree with that.
And then there's intranasal diamorphine, of course, which again I use on children occasionally when they're injured.
Great for the banana arms. Yes, I think in summary, loads of potential options if you had an unlimited pharmacy, etc., etc. And yeah, Jeremy, again, very good point. Use what you're familiar with. So similarly to Kitty, I'm somebody who's, and I'm sure Jeremy and Dave, happy using ketamine, certainly in a pre-hospital environment with the appropriate monitoring and a paramedic next to me. But I guess that changes with who you're with and where you are, etc., etc. So yeah, use it what you're familiar with. Don't cause any harm, being the key points. And I would not use IV lidocaine. So if there are no further points for discussion or any other questions, I want to say thank you to everybody who has spoken this evening, who has volunteered their time to come and educate us and inspire us. So particularly Kitty, thank you very much for providing the intro and for contributions from Dave and Chris and Jeremy. I also wanted to say thank you to all the BMMS trustees and committee members, and also to Chris for helping kind of support this venture, and helping me plan for this evening, and for helping me organise this evening as well. As you all know, I'm a bit of a technophobe, and without your help tonight, certainly would not have happened. And yeah, thank you to everybody watching this and in the audience. So lastly, in order to receive your certificate of attendance, Chris, please correct me if I'm wrong, people will need to complete the evaluation form at the end of the session.
They can find it in the chat right now.
Perfect, thank you very much. And we're aiming to use this to kind of improve future journal clubs. And then I believe that the certificate of attendance will be available on people's medal profiles, and from there you can download it. Is that correct, Chris?
Yeah.
Perfect. So yeah, thank you very much everybody for attending. Follow us on social media, so Facebook and Instagram and X as it's now known. Follow us on Medal, and then you should be able to hear about any future FOMED activity. And if you're interested in presenting at future journal clubs, the plan is that we're going to try and hold them quarterly if it turns out to be a success. You can email the BMMS by, I'll pop it in the chat now if I can multitask, sending an email to info@the bmms.co.uk. So you can email us here, and we will stick your name down on a list of people who's keen to present. By all means, send us some suggestions for articles as well. That would be great. Thank you very much, everyone.
And Jeremy has set aside some dates already for the next 3 quarters. So yeah, keep an eye out for those, and we'll hopefully just do the same again for those next ones. So yeah. Thank you all for coming. We will end the session there. Feel free to comment on anything in the chat, and we can continue replying after. But